A little bit. So I'm a geriatric psychiatrist. I'm a UH at Queens, and I do a lot of outpatient clinic care. We get a lot of referrals for dementia-related behavior from PCPs. I also do a lot of nursing home, hospital consultations. Again, usually related, for behaviors in dementia. So we'll spend the next 30 minutes sort of going over the highlights. So my talk is going to be kind of have follow this um, outline here. We'll talk about dementia prevalence and types, how to screen for dementia, dementia-related behavior. How do we go about addressing that medically, without side meds or with side meds? I mean, I can spend 2 weeks or even 3 weeks talking about all this in detail. But for today, we're going to try to condense it in 30 minutes. And I'm just going to share with you kind of what I consider very important things that you may want to take away with, from each of these areas, in a primary care setting. Okay. Okay. So how common is dementia? So if we look at a age group of people that are 60 to 65, there's about 1% of people with dementia. However, this prevalence doubles every 5 years. So if we look at people that are 90 years or older, probably more than half of them will have dementia. And with a life expectancy longer, with a baby boomer effect, United States, we're going to be looking at more and more people suffering from this illness. So I think dementia already has become the most expensive illness to treat in the United States, just given how frequent, how common it is. Okay, and when we talk about dementia types, or dementia for the rest of the lecture talk today, I'm going to be referring to Alzheimer's dementia because it is the most common. So Alzheimer's dementia comprises about 80% of all the dementia types. Some people have both. And speaking of both, the second most common type of dementia is Lewy body dementia, followed by vascular dementia, which is people with a history of strokes. And the reason I want to emphasize Lewy body dementia is that the diagnosis, the presentation, and treatment can be a little bit different from Alzheimer's dementia. So I just want to take a step aside talking about Lewy body dementia, and then we'll go back to Alzheimer's dementia.
Can you tell us if those are US numbers or worldwide?
I'm looking at, these are US authors. I would assume, if I have to guess, this is probably United States. Yeah, because dementia prevalence, it varies a lot, especially, in countries, where the life expectancy is not as high, as United States. And I remember when I did my rotations in certain countries, they almost don't see any dementia because people don't live that long. So a lot of infectious illnesses. So, okay. So if we just take, so what is a little bit different from Lewy body dementia as opposed to Alzheimer's? So Lewy body dementia has very recently been regarded as the second most common type of dementia. Even then, it's still very underdiagnosed. And the telltale signs of Lewy body dementia include cognitive fluctuation. This is where the caregivers or the family members can tell you that they have good days and bad days, and it fluctuates like a roller coaster ride. As opposed to the general decline. With people with Alzheimer's dementia. There's a lot of visual hallucinations, especially early on in the illness, a lot of REM sleep disorder. This is when people are talking out loud, acting out in their sleep. And then the Parkinsonian symptoms come a little bit later. And why is it important? Because if we try to treat behavior, specifically psychosis or aggression in Lewy body dementia with a typical antipsychotics, it's just not going to work. You're going to make their motor symptoms a lot worse. And I still see a lot of people being treated with risperidone or haloperidol for Lewy body dementia. It just is not appropriate. And so the medications of choice will be quetiapine and dementia medications like cholinergic inhibitors, like donepezil and rivastigmine. These seems to be a lot more effective for this specific type of dementia. And there's a newer medication known as pimavanserin, who's been approved for Parkinson's psychosis, but I think it's going to be approved for Lewy body dementia psychosis, if not Alzheimer's psychosis, in a few years. Okay. All right. So let's sort of go back to Alzheimer's dementia or dementia in general. Um, so how do we screen for dementia? So before we do that, I usually like to take people through the different stages of memory decline. Starting with normal to age-associated memory impairment, which is still normal. That's what I have. It just means that compared to people in their 20s and 30s, I would not be able to remember, as many words or as many shopping list items on a long shopping list. But otherwise, I'm still, I can still go about, doing my checkbooks, not forgetting to go to work. Um, and then what we're more worried about is when people progress into, mild cognitive impairment and dementia. Um, and according to new DSM-5 terms, mild cognitive impairment is known as mild neurocognitive disorder, whereas dementia is now called major neurocognitive disorder. But we still use the MCI in dementia because we're used to using those terms. So how do we catch people? How do we define mild cognitive impairment? It's operationally defined as people that score maybe at the 5th percentile or below, your education and ages and adjusted peers. But even with them, even with that, people with MCI do not have, what's known as loss of activities of daily living. So this is a sort of a picture depicting different types of activities of daily living from what's known as instrumental ADLs. This is a little bit more sophisticated as opposed to the more basic. And so even though, with the memory decline, there's still able to do most of these, if not all of them. And what differentiates dementia, and why is it important to catch people, that are MCI? Because about 10 or 15% of people with MCI per year will progress into dementia. And this is your, last critical window as primary caregivers, as primary care providers, to go over cognitive risk factors that are reversible, so to prevent the progression into dementia. So, and as you may have suspected, with dementia, there's not only cognitive decline, there's also loss of ADLs. Starting with the loss of ADLs are a little bit more complex. Okay. So, and this is how we, clinically diagnose dementia. But a lot of people would ask me, well, are there any, objective testing instruments that, people could do to help to support the diagnosis of dementia? So I would like to kind of go over a couple of screening tools that could be easily done, with very little training. To screen for dementia. And I would say my favorite so far, because we don't have a lot of time, in an office setting, will be Mini-Cog. Mini-Cog, we'll go over that a little bit later. It's a very short, elegant test for dementia screening, a lot easier to do versus a mini-mental status exam, which is a 30-point exam and can take about 10 or 15 minutes to do. And I'm pretty sure all of you are familiar with mini-mental status exam. And we're not going to go into this today, but if you're ever interested in sort of detecting MCI, the ones that I would recommend is St. Louis University mental status exam. It's a harder test, so it's more appropriate to screen for a mild cognitive impairment, and so we do that a lot as well. But let's just go into the Mini-Cog right now. So this is what Mini-Cog is. It doesn't get easier than this. It's a 2-item exam. So this is, where you ask the patient to remember 3 words, and then to repeat these 3 words. And these 3 words could, you can change it to anything that's, anything else that's, pretty common. And once you have them repeat the 3 words a few times, you ask them to draw a clock with a time that shows 10 past 11. Once the clock is done, then you ask them to recall the 3 words. And the way you want to score this is, if they're able to get 3 out of 3 on the recall, they probably have no dementia. 0 out of 3 on the recall of the 3 words, they probably had dementia. Whereas if they get 1 or 2, then use a clock as a tiebreaker. So if the numbers are all kind of equally spaced out, the long and the short hands are pointing the right numbers, then that would be consistent with no dementia. So how does this compare this algorithm compared to PCP's impression. And actually it's more sensitive and specific in detecting dementia versus PCP's clinical assessment. And what's nice about Minicog, especially in Hawaii, it's very robust among people who don't speak English as first language or who's very little English, because clock is universal, and you can typically find 3 words that people can understand, even with minimal English. So this is something where we do a lot, and I recommend you consider using that because it only takes a few minutes. Okay, all right. Okay, so let's go into so one thing about dementia is there's not just cognitive decline, there's also a host of behavioral symptoms that arise as the dementia progresses. Okay, and yeah, a majority of people will develop some types of dementia-related behavior, and so the catchword, the umbrella term for that is behavioral and psychological symptoms of dementia. And why this is important? Because it can predict mortality, it can predict earlier placement. People are not able to stay in, with their loved ones or their family because of the behavior. And also, it's very, very distressing for caregivers taking care of these individuals. Okay. So I don't want to just take, just another time out just to, step away from dementia, but to focus on, these caregivers for dementia. So they are at very, very high risk for depression. So this chart shows that, that maybe 5% in the general population at any given time will be afflicted with depression. And this rate is higher among 4-time caregivers of any illness or any disability, but this number triples to over 30% among 4-time caregivers of people with dementia. So often in our clinic setting, I tell the caregivers that we're as worried about you as we are worried about patients that that you're taking care of. And these are some of the known risk factors for caregiver burnout, depression, in dementia. So usually female caregivers that don't have a lot of, that have, maybe less education, stuck in the same house as the patient and feel like they don't have any other choice. So we always encourage them to get some help, to recruit families, friends, or look at programs and adult day programs. It's a pretty good, useful tool to access because a lot of people with Medicare have Medicaid. Adult day programs would pay for Medicaid, and even half a day or 2 half days a week would help the caregivers to get that little breathing room that they can help to refresh themselves. So we encourage a lot of that.
We do have a couple questions.
Sure.
How is the diagnosis of Lewy body dementia made?
Okay, so yeah, it would be going back to the core symptoms.
Mm-hmm. And then would you see it on MRI? The Lewy body?
There is it is still a clinical diagnosis, but there is a host of different imaging modalities now that you can use to help support or establish Lewy body dementia. So one of them is known as a DET scan. It screens, it detects for dopamine transporter binding by dopamine. And that's been used for Lewy body dementia diagnosis, Parkinson's disease diagnosis, and neurologists usually would order that. But you can diagnose Lewy body dementia clinically, and these are the 4 core features. And I'm not sure if you need all 4. I think maybe you just need like 3 out of the 4 for a diagnosis. So I would say the most specific for Lewy body dementia is a cognitive fluctuation that they have good days and bad days versus this general decline. And they usually get visual hallucinations a lot earlier than any kind of obvious memory decline or any obvious Parkinsonian symptoms. And then, REM sleep disorder in this context can also help to sort of establish that diagnosis.
So if you have patients with severe mental illness like schizophrenia or bipolar, as they age, how do you know if it's their mental illness or if it's dementia?
Yeah, I mean, that's a great question. 2 months ago, we actually had a patient with long history of bipolar illness developing Lewy body dementia. So bipolar illness, when they become psychotic, it's usually auditory hallucinations as opposed to visual hallucinations that we do see in Lewy body dementia. People with bipolar illness do not usually have Parkinsonian symptoms. They usually don't have REM sleep disorders. And when they're sort of manic or they're depressed, it's a pretty consistent mood state. Like either you're manic for like days or for weeks, or you're depressed for days or for weeks. It's pretty consistent as opposed to the day-to-day fluctuation. So in that bipolar illness patient, in that patient with bipolar, we start seeing these. And it's like, this doesn't look like bipolar illness. This sounds like Lewy body dementia, and her memory is starting to decline. Then we did a DET scan to confirm that, to show that she has a dopamine deficiency. So we're able to diagnose Lewy body dementia, and we actually had a case report and published it. Yeah, so because it can be very confounding, when you have mental illness and new onset dementia at the same time.
Yeah. Are there any causes, reversible causes of dementia, or is that just delirium?
Yeah, I mean, there's a lot. we so I would say if we look at medical illnesses, the top 3 medical illnesses that can be reversed to lessen the memory decline are hypertension, diabetes, and hyperlipidemia. So I always tell my patient that, hey, you can go out, you can convince your PCP to prescribe Aricept, donepezil, to help to slow down the memory decline. But the effect of that is going to be minimal compared to working with your PCPs on getting your cholesterol, your sugars, and your blood pressure under control. So that's one reversible risk factors. And other reversible risk factors are, diet, exercise, mentally challenging activities. Talk story doesn't count. It has to be, reading, joining classes, doing puzzles. So we do go over these with the patients too, especially those people that, they're still in that reversible, MCI window. Yeah.
Thanks. That's it for now.
Okay. Okay, so talk about the caregivers. Okay, so basically, dementia-related behavior could be broken down into these clusters that, for sort of specific targeted symptomatic treatment. From psychosis, agitation, apathy, altered circadian rhythm, which is, your sleep-wake cycle is all deranged, anxiety, and depression. And the reason I have psychosis and depression in red is, so these are the 2 symptoms that can add to risk for mortality, accelerated dementia decline, aggression, and they can be readily reversible if we catch it early enough, and we can reverse it with treatment. So I want to spend a little bit more time on these 2 symptom clusters. Okay, so psychosis in dementia, usually involves, getting confused, thinking they're somewhere else, thinking they're kidnapped, not able to identify their family members anymore, paranoid about, things being stolen, and unlike people with bipolar psychosis or schizophrenia, their hallucinations are usually not auditory, they're usually visual, seeing things, and then they'll call the police, they'll throw knives at, these intruders. And this, can be more common, 25% as dementia progresses. And why is it important? Because psychosis, talking about reversible risk factors for aggression in dementia, psychosis is one of those, because it's correlated with, physical aggression, institutionalization, and higher risk of death. So something that we always want to catch in evaluating a person with dementia-related behavior. Okay, and the other thing is, the other major symptom is depression. So, family members would tell me that, hey, if I were, if I had dementia, I would be depressed myself. But that's not really the case because only about 20% of people with dementia have depression. The other 80% are they're you know doing relatively okay. The risk is higher among people with Parkinson's disease dementia. And life psychosis, this is also predicts physical aggression, mortality, and faster memory decline. So this is something that we can really treat and reverse to try to maintain that quality of life. Um, and of course, people with dementia, with the memory decline, they're not going to be able to tell you that, well, hey, I'm depressed, I'm suicidal. So what are some of the specific signs, that you could, help to sort of identify as something that's specific for depression in dementia? And I would say, being irritable, that's probably the most important word that I go over with the caregivers is that when they're irritable, they're usually depressed. Irritable means that they don't like to be talked to, they're rejecting care, they're turned away, you cannot make them to do anything, they just want to like just isolate. And that's usually that's probably one of the most specific signs of depression in dementia is irritability. Um, and one of the main reasons we worried about depression is suicide. So if we look at suicide rates in the United States, there's a dramatic spike of successful suicides by older male, as seen, right here, and usually, by firearms, and when do these older males usually, try to, engage in suicidal behavior? Usually when shortly after the dementia diagnosis, especially in those with mental illness. So this is really, really a critical window that you want to screen for any signs of depression. Okay. So how do we detect depression? You can do it clinically. And you can help to support that by depression screening instruments. And I'll just go over two today. The one that we use a lot and is pretty popular nationally too is what's known as a geriatric depression scale. It's a 15-item yes or no question, and basically any answer that's consistent with depression would get you a point, and 5 points or higher will be consistent with depression. And this is meant to be read out loud to the patients, not have them read it and score it themselves. It's not designed to be done that way. So we do this a lot in the clinic setting. However, it's not really valid for people with moderate to severe dementia because they're not able to understand these questions as well. And moderate to severe dementia, probably looking at people that have a mini mental score of 15 points or less. So in that context, if you still enthused about doing some sort of screening tool, sometimes we'll do the CSDD, known as a Cornell scale for depression and dementia. So rather than asking the patients, directly about, different questions, this is done with the caregivers who knows the patient well. And you just kind of go over these, anchor symptoms, and you can score them as, absent, mild, or severe, within the last, I think, 1 or 2 weeks. So something you may want to consider doing. Okay. All right. So now, so we have, some idea about dementia-related behavior. So what are some of the tools that we could invoke to try to lessen this behavior? So you may was, people start thinking about, let's start adding medications, but not really. Well, before we do any of that, we want to make sure that they're not delirious. People get psychotic all the time, acutely, from a urinary tract infection or any kind of, infectious medical etiology or like a stroke. So we want to make sure that's not going on. And before we add medications, we always want to go over their medication list. For any new medications, especially any medication with anticholinergic effects, because those are very, very confusing, can cause a lot of confusion, a lot of falls. So, and they usually can precipitate a lot of symptoms. And then two more things that we want to go over is constipation. So psychosis, depression, and constipation are usually known as some of the most reversible risks for aggression in dementia. So we always want to make sure they're regular BMs. Um, and in an outpatient setting, we typically ask the patient's family to get Miralax over the counter. That seems to be not very harsh, as opposed to the laxatives or Senna. And then also pain. If you're hurting, you're going to be aggressive. And conservative treatment sometimes involve us recommending Tylenol or acetaminophen. That seems to be one of the safer, if not the safest pain medication to be used in this population. Okay. All right. And so let's just go into so non-pharmacological treatment versus pharmacological treatment for dementia-related behavior. So where do they, so what is the role at it? So this is what I conceive as timing for non-pharm versus pharmacological treatment. So this graph shows that when the symptoms of dementia related behavior worsen, there's a decrease of quality of life. And this is where non-pharmacological approaches will come in initially. If you apply that, you can help to maintain that quality of life. However, as the severity of the symptoms worsen, it's not going to be as effective. And this is when medications, when used judiciously, can help to maintain that quality of life. Whereas inappropriate use of medications, then you make it a lot worse. Okay. So we're just going to start by what are some of the very sort of important non-pharmacological approaches that we go over with our patients of caregivers. When they're agitated, there's usually some sort of unmet needs. They're hungry, their diapers need to be changed. So we empower the caregivers to kind of figure it out, think on their feet about whether what could be missing or what they could be trying to tell you, or instead of always asking the doctors for medication. And also we encourage the caregivers, because sometimes if we see the caregivers kind of getting frustrated, yelling at the patients, there's probably some sort of caregiver burnout, or they're sort of not using the approach, the language that is more specific and more appropriate for people with dementia, which is kind of speaking slowly, gentle touch, using a lot of gestures, and always approaching from the front so they're not surprised. And always make sure that they're going to be stuck in their room for the whole day. They're going to be they'll have a lot of sensory deprivation, and they're going to be doing stuff on their own and being agitated because they lack the stimulus. So we always challenge the caregivers to provide some kind of sensory stimulation, with music specifically, because it's one of the very few non-pharm interventions that have been shown to be effective as opposed to the others. And when they're paranoid, they're hallucinating, unless they're doing anything that's dangerous, I ask the caregiver just kind of go with the flow. If you're accused for stealing money from them, just apologize. Don't argue. If the more you argue, the more agitated they're going to be. And then once they come down a little bit, then find ways to distract, the patient to start thinking about something else. And always trying to find out, these individual activities that they may like to do, like tying knots or folding napkins, doing crafts. This can help a lot in just, having them feel like their days are occupied. So, toward the end of the day, they're ready to rest versus being sensory deprived and start, going through this vicious cycle agitation because they're lacking stimuli early in the day. So every few years, the City of Honolulu has published this very nice, informative, comprehensive senior handbook listing different day programs and resources that we frequently would give out to the caregivers to help them to access more help. Okay, all right. So so let's talk about medication. So even though, non-pharm interventions are great, because there's no adverse events, because you're not giving medications. But if you look at the evidence, it is not as impressive, except for music. So this is a meta-analysis show that of all the different types of non-pharmacological intervention, only music therapy has been shown to be sort of consistent in decreasing the overall agitation. So this is, any bar that's left to the dotted line is effective. And when we talk about music therapy, we're talking about music specifically that the patients listen to when they're sort of teenagers. So this is music that they're familiar to them, when they're growing up. And I think, and this will be probably like, the early oldies, right now, for the patients, with dementia at this time. So, and I'm not going to spend a lot of time on the medication choices because I was just, informed that a lot of the audience is non-providers, but, I'd be happy to answer any specific questions later on in the Q&A. So once we start thinking about, hey, we've done our due diligence and medical assessment, we try all the non-pharm behavioral approaches already, but they're still agitated, they're aggressive, they're psychotic. What do we do? Yeah, this is when the medication we have to be considered. Well, there's no such thing as an FDA-approved medication for behavior and dementia, so we have to use medications that have, highest, benefit versus risk ratio per available studies. And this is kind of a summary of different medication groups, array according to their benefit versus risk. So we obviously want medication with a high benefit versus low risk. So this is pretty much, we're looking at our antidepressants, SSRIs, Prazosin, whereas antipsychotics, yeah, they can be even more effective, higher benefit than the antidepressants, but it does come with a much higher risk, higher risk. Benzodiazepines, we typically don't use it, high risk, low benefit. And mood stabilizers, like Depakote that I see a lot, there's really no good evidence to show that it has a acceptable benefit versus risk ratio. And this is, a lot of, people try to line up, these symptom clusters of, dementia-related behavior with, first and second line choice of medication. This is one of the examples here. And this is something that we developed here in Hawaii a few years ago, with the sort of the, dementia medication algorithm for PCPs that is evidence-based, and we do modify from time to time. So you just kind of pick the symptom that is distressing the patient or the caregiver and just kind of follow the line. And as you can see, it's, depression, hallucinations, agitation, we still consider the SSRI, the citalopram specifically as the first go-to medication. Okay, so I'm just going to stop here a little bit, because otherwise we'll be talking about specific medications. But you know what? I'll just one more slide. So there's just so much more good evidence now coming out with SSRIs, your typical antidepressants. And I'll just use citalopram as an example. It's a selective serotonin reuptake inhibitor. It doesn't have a lot of drug-drug interaction. And there's a lot of, with COVID, there's evidence now showing that, these SSRI class of medications can confer anti-inflammatory properties. So people that have a stroke or even COVID, they actually have decreased memory decline and decreased mortality being on an SSRI, even if they're not depressed or anxious. There's study now showing that people on SSRIs have less COVID-related hospitalization. And it is as effective as risperidone in decreasing a lot of different types of dementia-related behavior. So SSRI has sort of been our first line for if we have to use medications. And something you want to watch out for if your provider is SIADH, hyponatremia from SSRIs. Usually you see that in the first 2 weeks. So I will usually get a BNP baseline and 2 weeks later, just to make sure that's not the case. Yeah. Okay, I think I'll end the talk today, but if you have medication specific questions, I have more slides for that, so we can go over that. Okay.
So questions? Anybody have a case? If not, I'll introduce one. I have a 92-year-old female who lives at home with family, and she is moderately demented. She has had a lot of paranoia, and her family is frustrated living with her because she doesn't necessarily recognize them, and definitely doesn't appreciate them taking the time to try and work with her. And they've gone through some Alzheimer's training programs locally, and so they are good with they understand how to interact with her, but she seems to be getting more belligerent. She's on sertraline 50 milligrams a day. Her blood pressure is well controlled, no diabetes, her cholesterol is well controlled, but she seems to be getting more challenging for her family, and I'm worried about her family actually.
Right.
More than her necessarily, because she's clinically doing pretty stable, but she's getting more agitated.
Okay. Well, so my first question is, what is she paranoid about? Is it about something that is sort of innocuous and family can just kind of go along with it? Or is a paranoia so bad that involves like dangerous, activities or action?
It's you're trying to take my money. You're
Okay.
you're not listening to me. You're sometimes it's, who are you? You're a stranger. What are you doing in my house? And
So how would a family respond to that? I mean, do they get, I hope they don't get defensive. They get defensive about, hey, I didn't take your money. How could you accuse me? That's just going to get her more, worked up.
right. So they're reassuring, but they get tired of being reassuring after multiple times. So they reassure, they distract her. They have foods that she likes that they give her. She has certain television programs, and she does certain things with a community group.
Well, that's great. So it seems like you have worked with the family a lot, about optimizing, non-pharmacological options. So if she's on sertraline, maybe you can consider switching to citalopram and escitalopram. The evidence for these medications for dementia-related paranoia, it's still a little bit better than sertraline. And if that doesn't work, then you may have to consider, antipsychotics. So these are the so aripiprazole, risperidone, olanzapines, if you look at all the different meta-analyses that have been done, these are the sort of the three tried and true antipsychotics that can help with aggression, psychosis in dementia. But if you look at the doses, they're pretty low. So not anywhere near the ones, the dose that we need for schizophrenia. So this is what I would consider. But of course, the caveat is you want to make sure it's not Lewy body dementia, because any of these medications make the Lewy body dementia, motor symptoms and behavioral symptoms worse.
So there's lots of comments coming in. So let's see, did the family move in with her, or did she move in with the family? So the family moved in with her, and she's often accusing them or the husband, her daughter's husband, of being a liar and a thief, breaking into the house, stealing the tools, or she doesn't trust the doctors. The doctors are lying. The neighbors are trying to take her property. And let's see. Okay, so switching her over and then maybe adding one of these could be helpful.
Yeah, because I mean, we're looking at a pretty low quality of life now, right? She's living in this constant distress or fear, something bad, someone's gonna steal from her, or there are intruders in the house all the time, and there's only so much redirection you could do. Yeah.
Yeah, would more activities be helpful, or is she likely to, yeah?
Well, oh yeah, always. Yeah, the more you occupy her, with individualized activities that she likes to do, that's part of distraction. But it sounds like the severity of her paranoia is pretty bad. That there's only so much you could do without medications. And this is when we would work with the family that, hey, do you feel like you have done as much as you could? And before talking about medications, and these are some of the side effects, and we'll support you either way. But usually by then, the families are so exhausted that they will be usually open to a medication trial.
Okay, anybody else have advice? She is not a flight risk. Let's see. There's a question about, are there any natural remedies or supplements you recommend for dementia?
Yeah, a lot of people had tried marijuana or CBD oil, but I would say there's really not a good evidence for that. And from sort of anecdotal tales from my patients, sometimes they work, sometimes they don't. CBD oil sometimes can predispose people to more psychosis, especially you have kind of like genetic or biological risk factors for that. So I would say I don't want to say not trying that. I would tell them that right now we don't have any good evidence to support that, but it doesn't mean at an individual level that it wouldn't work. So if they rather try these natural remedies, specifically the CBD oil, then I would be okay with that. And if it works, great. If it doesn't, then we can just go through this evidence-based treatment algorithm.
Right. And another question is, what has been your experience with clients with dementia in care facilities not eating, leading to rapid decline in health?
Yeah, okay. So, I mean, it's multifactorial. There are a lot of causes for that. If a person has a pretty significant medical illness, like colon cancer, cardiac or stroke, one of the consequences is that they're just not going to eat because they're so physically debilitated. And this is when you might want to consider hospice. But otherwise, if they're medically stable and they're not eating, we would look for, we just make sure that there's no dysphagia, they're swallowing okay. But if that's all addressed, then what we would, as I had talked about earlier, we would want to screen for depression, right? Medically stable person not eating, that's a high risk, that's high chance that the person will be depressed. And if we think the person is depressed, we would treat with medications or trying to figure out things that's causing the depression. Often it's a family member, so the children not visiting or they don't have any activities. So we would try to get all those resources or the visits that we think we can get for them. And if still that, and often concurrently, consider medication as well.
What advice would you have for the family? What else can they do?
For dementia-related behavior?
Mm-hmm.
Yeah, I mean, I would say, people with dementia, especially with those, with psychosis, they're sort of living more than ever in sort of alternate reality, and sometimes it just makes more sense for you to just go along with that. as long as there's sort of alternate reality or alternative facts, I don't want to sound political here, or alternate reality is not distressing to them and they're not doing anything dangerous, just kind of just go with that. Because too many times the family's effort to bring them back to reality that, hey, there's no intruder, I'm not stealing from you, no one is doing these horrible things to you, that it's just going to upset them even more.
Got it. All right. Any other insights from the group? Any other cases from the group? Maybe we could go through the rest of your slides. Would that be okay?
Oh yeah, sure. And it needs to be available upon request too. So this is for, people worried about risk of medications, antipsychotics. So then I would just kind of show them the actual numbers. So, this is the black box label for higher risk of death in people with dementia taking antipsychotics. Well, what numbers is it really? What does it translate into? So I did some search, and we're looking at increase of risk of death from risperidone from 3% to 4%, and that could be depicted as 33% or 50% higher risk of death, right? Because you're increasing on 3 to 4%. So that is your risk. What is your benefit? Yeah, studies have shown that if you have physical aggression and if you get risperidone, there's a 50% or higher chance that the person will get much, much better. So when they weigh the benefit of this large percentage of quality of life improving versus a 1% increase of risk, they understand that that they may have to try the medications, because of higher likelihood that their quality of life will be vastly improved. And then the benzodiazepines, there's an epidemic especially in females. At 12% of female age 80, this is age. 12% of females age 80 are prescribed in benzodiazepines, and usually not by a psychiatrist. And we think that studies have shown that this is because the PCPs are more familiar with benzodiazepines, and they're having to be asked to do a lot of mental health care in older folks. And we're trying to reverse that because there's really no evidence to show that benzodiazepines are effective in dementia-related behavior. You actually can make it a lot worse, because they get disinhibited, they get a lot worse when they wake up on their benzo buzz. That's what we call it. So. All right, and going back to antipsychotics, my last slide is, if you do use it with discretion, small doses only for aggressive psychotic behavior, using antipsychotics in that setting is not associated with any higher risk of death or greater nursing home admission. So it can be safely used to maintain that quality of life. Conversely, it is the untreated psychosis, untreated depression, that is a predictor for people doing a lot worse, a lot quicker, and a more aggression and earlier institutionalization. Okay, any other comments or questions?
Yes, we do. We have a lot of comments now. So Dan Alicata says, thank you, Brett. How are we doing regarding availability of statewide resources for patients with dementia and their caregivers?
I don't think we're doing too well. There are very few providers specializing in older people with dementia. So the PCPs are having to do a lot of that. We talked about that. There's a huge shortage. I don't even know where to get started. But I mean, Kelly, Dr. Witty, you're in the fields, in the trenches a lot more than I am. I mean, you are the expert, right?
We have shortages
in niches where where there are needs. So how does mental health care for older people compare to other needs that we have in the state?
Well, we have a shortage of psychiatrists. We have a shortage of geriatricians. So geriatric psychiatrists, very short. Yeah, very short. So we do have that need. Let's see. And Renata asks, how does changing the scene or location alter her reaction to the family? I think from what the family's told me pretty well, distracting her works well. So maybe agreeing with her. Oh, okay, let me ask you this. If the family were to agree, oh yeah, maybe the neighbors are stealing something, we'll put up a little fence here. Is that, because you said to not contradict them so much, but is that creating an expectation of, I don't know, expectation of evil? Or is that okay?
Well, so I mean, I think it's okay because the family, I mean, so at that point, that's what being a surrogate is all about. I mean, the patient with dementia, they lack the capacity to understand what's going on. So the children in this case, as a surrogate, have to be sort of making some decisions about responsible care. What kind of treatment he or she deserves. And if putting out a sign saying that the neighbors apologize, or the neighbor's not going to do this anymore, or hey, this sign, the neighbors see that every day and they stop doing that. If that helps to lessen their distress, in their quote unquote alternate reality, that's all, I'm all for that. Yeah.
Okay, and then Erica asks, how is dementia diagnosed in an elderly man that has a long history of alcohol use? How do you determine if memory problems are exacerbated by his heavy alcohol use or dementia? So kind of like our question earlier,
Yeah.
with psychosis, but this is with continued long alcohol use.
Right. I mean, you could never tell. So you start thinking about what is the most reversible. The most reversible is still asking the person to stop using alcohol. So I mean, there is such a thing as alcohol-related alcoholic dementia. So that's probably what's going on. And so all efforts you go into getting the guy to stop. And what's a little bit different from alcohol-related dementia as opposed to other types of dementia is alcohol-related dementia is one of the dementia types that is the most reversible. So often we see that, when they stop drinking, a lot of their cognition can be, cognitive decline can be reversed. So that's my answer. Yeah.
All right. Megan says, with my grandmother, we used to use music as a comfort tool, and it had a surprisingly effective grounding effect. Could
Yes.
even turn around episodes of crying or general upset sometimes. Also focusing on letting her know she was safe seemed to be calming, even if unable to completely talk her out of a delusion. That's good advice.
Yeah, thank you for sharing that. Yeah, music is a very, very powerful calming tool, especially music that we were familiar with. So no classical music. Yeah.
And then we have a couple more questions. Family is without explanation of cause of death. What are regulations in care facilities to ensure adequate medical care and determine cause of death?
Yeah, I'm not sure I could answer that. I'm usually as a behavioral health consultant in nursing homes. They have protocol for announcing death and looking at the causes. Usually the medical director or the primary care physician responsible for that would look into it. I would not be, yeah, I don't think I can answer that question.
Okay. Is the increased risk of death and depression in the elderly compared to normal people or people with untreated depression? So the increased risk of death in the elderly, is it compared to normal people or people with untreated depression?
Yeah, so increased death in elderly with depression, that is compared to people without depression at the same age.
Yeah. Okay, and so back to this access to care, how long is the waiting list to see you?
It's hard. I mean, we're inundated, as you say, that there's so few geriatric psychiatrists. So we have pretty much evolved to a referral clinic. So at Queens, for example, most of the sort of milder cases or milder symptoms of behavior in dementia, they're all addressed by the geriatricians, the PCPs. And once they're not able to handle, or they need a second opinion because the medications are not working, or this is pretty severe, they would make referrals to us. So the wait time usually is about 2 to 3 months.
Okay, but people can get in. Okay.
Yep.
Renata wonders if the 92-year-old forgets her family moved in with her. Maybe if the space the family occupies is well defined for the grandmother may help. GMO. There's another quick case here. Mark says, a case I was involved in involved multiple mental health psychiatric evaluations in the hospital emergency, where individual was discharged after being deemed not suicidal and having capacity. Finally, neuropsych testing was done and patient was involuntarily committed because he was deemed to have dementia versus psychosis. What would you suggest in future to prevent misdiagnosis of mental capacity? So it sounds like he would go into the emergency room suicidal, but then they would release him. But then
Yeah, well, right. Well, I mean, yeah, it just depends on what mental capacity or what capacity. I mean, there are different types of capacity evaluations. But I would, regardless of, mental health diagnosis, some people with dementia can live alone, with support, and some people cannot. So as opposed to a diagnosis-based capacity evaluation, we would look at sort of the context, the context. So if somebody is coming to the ER, and you say that the question is safety, then we can do a capacity assessment for safety. So I would ask questions about, do you know where to get food? You know how to get 911, or if you get in trouble, where do you go for care? If he or she's able to answer all those questions consistently, then he or she may have quote unquote capacity for self-care to meet basic needs, and then we may let the patient go. But conversely, if this person has the memory decline is so bad that he or she's not able to demonstrate any capacity to get shelter, to get food, and has this raging infection, in her foot, and not knowing that he needed treatment, yeah, that person lacks capacity because that person is imminent danger, from, once, if released. Yeah.
Well, thank you so much. There is one question left, but we're out of time. So let me just tell the group, next week, we're hearing about preventive services offered by Medicare and how to access them. So community resources. And thank you so much for the talk. I'll tell you what the last question is. Anybody can leave if they have to leave. So if the risk of depression related to death is known to be present, then how are we to interpret black box warnings for medications used in geriatric depression? And
right.
is this really
again,
real?
It's always a benefit versus risk decision. So if a person is sort of mildly depressed, mildly psychotic, and you can address those symptoms by, having more family visits, or by getting the person into a adult day program, for example, then you can treat the symptoms without medications. And because in those cases, using medications, you're not going to have that enough of a benefit versus ratio, because now on the other hand, if somebody is suicidal, not eating, rejecting all care, then the benefit for treating this person with antipsychotic, antidepressant would greatly outweigh the risk of the black box warning. So it all depends on the severity of the symptoms that you're looking at.
Great. Thank you so much. This was very helpful. And maybe we can have you come back sometime late next year, but I'll let you work that out with Dana.
Okay. All right. Well, I enjoyed it. Thank you for all the questions.
Thank you.
Okay.
All right. Have a great week, everybody.
Thank you.